My name is Myrene Guevarra. I am a family nurse practitioner student and will be doing my case presentation on a very interesting case I had encountered this semester. My goal is to share my experiences and hopefully provide awareness on management with scenarios just like this one. The patient who came into our urgent care is a 42-year-old Caucasian male with complaints of left-sided chest pain that had been occurring for about a week. This is his second urgent care visit. He had stated that he went to a different urgent care 1 week ago for right-sided chest pain that had been present for about a week, similar to the pain he is experiencing now on his left side. He was diagnosed at the initial urgent care visit with costochondritis. He was given a Toradol injection at the urgent care. Chest x-ray was ordered, and he was sent home with a prescription of azithromycin, the Z-Pak, and ibuprofen 800 milligrams for pain. He had already completed his azithromycin doses and also brought a copy of the chest x-ray that he did. It showed a mild right pleural effusion and nothing else significant. He is now complaining of diffused tenderness to his left chest and no more pain and resolution of the symptoms on his right chest. His pain scale is a 9 out of 10. It is intermittent, sharp, stabbing all over his chest, and he states that it doesn't radiate elsewhere to his body. It doesn't radiate to his shoulders or arms. His aggravating factors is when he take deep breaths, is when he feels the sharp stabbing pain on his left chest, um, and nowhere else. He stated that he had been taking ibuprofen 800 milligrams every 6 to 8 hours, and there is no relief of symptoms and no relieving factors that help with his chest pain. He stated that he has not traveled elsewhere within the last few weeks. There is no trauma to his chest. He has not been into any accidents. He has not hit his chest elsewhere. He also denies having any fever, wheezing, no cough, no shortness of breath, no heart palpitations, no weakness to his arm and legs. He doesn't have any bloody cough, no swelling to his arms or legs, and no bruising on his chest. So his skin is intact. The patient has a past medical history of hyperlipidemia and seasonal allergies. He has no prior surgical history, nor has he been hospitalized in the past. His family medical history: his father is alive and well, age 70, with a history of hypertension, hyperlipidemia, and CVA at age 60-ish. His mother is also alive and well, age 68, with a history of hypertension, diabetes, and CVA at age 50-ish. His brother is alive and well, age 49, with a history of diet-controlled diabetes and hyperlipidemia. He states that he does not take any medication for his hyperlipidemia and allergies. However, he has been taking his ibuprofen 800 milligrams every 6 to 8 hours for pain with food, and he states that he already had completed his Z-Pak. He has no known drug allergies and seasonal allergies with pollen. His diet mainly consists of fast food meals. He states it's Burger King or McDonald's or pizza, whichever is convenient for him to pick up and eat while he is driving on his way home for dinner, and then to work for breakfast. And he usually buys food from the vending machine for lunchtime. He drinks about 3 to 4 sodas per day and very minimal water. On a good day, he states that he only drinks, 5 cups of water per day. He has no issues sleeping at night. He sleeps about 7 hours per night, which he states is his baseline, and he states that he feels fine with the 7 hours of sleep. Regarding health maintenance wise, he has not followed up with his primary care physician for the last 3 years. He does have a primary care doctor. He does have insurance coverage. However, he states that there is no need for him to see his primary care physician. He feels fine, so he has not made an appointment for the last 3 years. He follows up with his dentist yearly for a yearly cleaning, and he had received his flu vaccine last year. He is a single male. He lives at home alone with no pets. He works full time as a warehouse employee where he lifts about 30 pounds um, of package, and he is a non-smoker. He drinks beer socially with his friends, about 1 to 2 beers per week. No history or current illicit drug use, no use of marijuana or any hard substances. And sexual history, he states that he is monogamous. He is sexually active with a female partner and no history of sexually transmitted infections. With a review of symptoms, the patient um, states that he has no fever, no chills, no recent weight gains or weight losses. He doesn't complain of any fatigue or weakness, no malaise, and no sleep disturbances. He denies having any headaches, syncope, vertigo, or congestion, nor no sore throat. Breathing wise, he denies any coughing. There's no sputum, there's no hemoptysis, no shortness of breath, no wheezing. He was complaining of a pleuritic chest pain. He said it's all over his left chest as described on the history and of present illness. Cardiac wise, he denies any palpitations, no cold sweats, no shortness of breath on exertion, no swelling on his arms or legs. Stomach wise, he doesn't complain of any reflux, no nausea, vomiting, diarrhea, or constipation. He also denies any shoulder pain, muscle pain, joint pain. There is no back pain. So he states that his symptoms was mainly on his left chest and not elsewhere on his body. Upon physical assessment, the patient's vital signs were noted to be within normal limits. He is obese with a BMI of 32. He was pleasant and cooperative, answering questions appropriately, other than the occasional facial grimacing when he inhales due to pain. His pupils were equal, round, and reactive to light and accommodation. Extraocular movements were intact. Nares were patent. Pharynx are clear without erythema. There is a non-distended jugular venous pressure at 2 centimeters waterline at a 45-degree angle. His breathing was regular and unlabored. He had symmetrical chest expansions and relaxation of his chest wall muscles. His lungs were clear on all fields upon auscultation, anteriorly and posteriorly. When I palpated along his second to fifth costochondral junction, he complained of pain and tenderness on the left side. His Wells score is a 0. The Wells criteria will be shown on the next slide. Cardiovascular-wise, he had a regular heart rate and rhythm. S1 and S2 sounds were auscultated. There was no murmur, rubs, or gallops. A 12-lead EKG, which will be shown on the next slide, is showing a rate of 75 beats per minute with no ST elevations or depression. His abdomen was soft, round, non-tender, non-distended, with active bowel sounds upon auscultation. There was no hepatomegaly nor splenomegaly upon palpation. Musculoskeletal wise, he had a full range of motion with normal tone on strength to his upper and lower extremities bilaterally. Unfortunately, I was not able to attach a picture of the patient's EKG with this slide due to possible HIPAA violation and the clinical policy at my clinic. However, I will discuss the findings of his 12-lead EKG in wording, and it is as follows. So he had a normal sinus rhythm with a rate of 75. He had an enlarged tall P wave on leads 2 with a 0.20 second interval. He also had an inverted T wave on leads 3 and AVF. And other than that, all the other leads were within normal range. His well score is a 0, as discussed earlier, and this is done to assess the patient's risk for pulmonary embolism. So he had no clinical symptoms of DVT. There's no leg swelling, pain with palpation. He had no other diagnoses that is less likely to make me think that he has pulmonary embolism other than his chest pain. His heart rate was 75, which is less than 100. He is ambulatory with no history of prior surgery, no prior history of DVT or pulmonary embolism. There were no hemoptysis and no histories or concerns for malignancies. So based on his Wells score of less than 2, he had a very low probability of having pulmonary embolism, and that he had most likely be unlikely to be diagnosed with pulmonary embolism based on this Wells criteria. This visit code was billed for CPT code 99214. Due to the atypical symptoms that the patient was experiencing, it was difficult to formulate a diagnosis for the patient. This case was discussed with my preceptor, another NP within the urgent care clinic, and with a physician who owns the clinic who works on the family practice side. A consensus of the diagnoses with the patient was decided that the patient has unspecified chest pain or R07.9, as well as pleurisy or pleuritis R01.1. Pleuritis is the inflammation of the lung pleura which may cause chest pain. Potential causes are autoimmune disorders or medications such as INH, hydralazine, or procainamide, in which the patient has not been on any medication, and we do not know of any autoimmune disorder that the patient may have. The differential diagnoses are M94.4 costochondritis. Costochondritis is a musculoskeletal pain from musculoskeletal inflammation or injury, with findings of diffuse tenderness at the upper costal cartilage and costochondral junction or costosternal junction without erythema, swelling, or edema. So we pick costochondritis due to, as evidenced by his pain and tenderness on his second to fifth costochondral junction. It was also discussed that another potential differential diagnosis is Wellens syndrome. So Wellens syndrome is a manifestation of a myocardial ischemia where the patient has chest pain and will present up on EKG findings with a T wave inversion on the precordial leads, which are V1 to 4, without ST elevations or depressions, nor any abnormalities on cardiac enzyme. So this condition is usually caused by the narrowing and constriction of the LAD, or the left anterior descending artery that supplies blood to the anterior ventricular septum and greater portion of the anterior left ventricle. Pulmonary embolism was one of the differential diagnoses that I proposed. As the patient was experiencing pleural pain upon inspiration, he was having sharp stabbing pain when he takes a deep breath. And also because of his family history, his father and mother had histories of hyperlipidemia and CVAs at age 60 and 50 respectively. ACS is one of the differential diagnoses that we also included due to chest pain, and as evidenced by the EKG with the T-wave inversion in leads 3 and AVF, and an enlarged P wave in lead 2. With a plan for the patient, a diagnostic test of repeat chest x-ray was ordered, and a slip was provided to the patient so that he can go to an outside chest x-ray area so that he can have his chest x-ray done. We gave him a prescription, or the nurse practitioner had given him a prescription for Tylenol number 3. He is to take 1 tablet orally every 6 hours as needed for pain. We educated him to go to the nearest emergency room or call 911 when he develops shortness of breath, severe chest pain, pain that is not resolved with a pain medication, edema to his arms or legs, or fever. We discussed with him to take his medications as prescribed, discussed the effects and side effects of Tylenol number 3, which could cause him to become drowsy, and to avoid driving or doing anything dangerous that could cause him harm. And the side effects of the medication, he is to take it with food. It may cause some nausea, vomiting, and constipation. He was given a note to be off of work for 3 days because he is not to do any heavy lifting, weight training, or pushing. And he was also instructed that he could use some cold packs or warm packs to help with his chest pain. We had instructed for him to follow up with his primary care doctor in the next 3 to 5 days. This particular case left me perplexed on what the causes of the patient's left chest pain was. I agreed that the diagnosis of unspecified chest pain was justified due to the lack of additional diagnostic testing needed to find out what the cause of his pain was. However, I felt uncomfortable to discharge him home without additional testing done or ordered at an emergency room setting rather than urgent care. I felt like the patient's sharp stabbing pain upon inspiration necessitates additional testing that could not be done at our urgent care. My preceptor and the physician emphasized that his well score is 0, which makes him unlikely to have a pulmonary embolism. His vitals were stable. My other concern was that the patient has not followed up with his primary care physician for the last 3 years, and I felt like he may not follow up with his doctor within the next few days as recommended. So I did offer for the patient to be sent to the emergency department that same day if his chest pain was really causing him severe distress. However, the patient opted to get the repeat chest x-ray instead, and that if his symptoms worsen or his chest pain worsened, then he would go to the nearest emergency department. Another concern I was having with the patient's EKG reading showing that some abnormalities. It is normal sinus rhythm. There were no ST elevations or depressions. However, I was questioning on why the EKG would show inverted T waves on lead 3 and AVF, as well as tall and large P waves on leads 2. Everything else is within normal limits. So with our clinic, the guidelines for chest pain in an outpatient clinic recommends to triage the patient and have his vital signs taken immediately to determine clinical stability. And if the patient is clinically unstable or with life-threatening conditions, that the patient be transferred to the nearest emergency department. H&P was completed, and a 12-lead EKG was done as recommended by the guidelines, as well as a repeat chest x-ray was also ordered. So the clinic followed the guidelines and protocols. However, it seems like the patient's symptoms from having a right-sided chest pain for 1 week, and then within the next week transferring to the left side was quite concerning to me, and I felt like discharging him home was not safe. However, the patient did go home, and we followed up with him the next day. The next day, we checked the RadNet X-ray portal to see if the patient had went and gotten his repeat chest X-ray. He did, and it showed the same right mild pleural effusion similar to the first chest X-ray done the week prior. However, it also showed a new 2 centimeter left lower lobe nodule. So we made a follow-up phone call to the patient just to make sure how he's doing. This time he sounded dyspneic with shortness of breath on the phone, and he mentioned that he had new swelling that had developed overnight to his left clavicle with pain and tenderness. So we instructed him to go to the nearest emergency room. However, he returned back to our urgent care instead due to his fear of contracting the coronavirus. With this return visit, the patient's condition had dramatically changed compared to the day before, where his vitals were now unstable. His blood pressure was normal, it was 110/63. However, he was tachypnic with a rate of 30 breaths per minute. He was tachycardic with a rate of 120 beats per minute. He was diaphoretic, and his oxygen saturation was 90% on room air. So he was having difficulty speaking with shortness of breath. Therefore, a 2-liter nasal cannula was placed on him, and his oxygen saturation went up to 95%. His lungs were diminished on the basis upon auscultation compared to the previous day, which was clear, and he had marked swelling and edema to his left clavicles that were tender upon palpation. He states that his left chest pain is a 3 out of 10 due to him taking Tylenol number 3, but because of his unstable presentation, we discussed thoroughly with him that the best course of action was for him to be transported to the nearest emergency room via ambulance, as he really needed to be evaluated to find out what the cause is of his symptoms. He agreed, and an ambulance was called for him to pick him up to send him to the nearest emergency room. And we also send an emergency department referral form with the patient. So we made a follow-up phone call with the emergency department physician that same day, and his CT chest result were read as follows: extensive pulmonary embolism including saddle thrombus, lingular and right lower lobe pulmonary infarcts, small left pleural effusion with mild basilar atelectasis. Questions for this cases are, what are the significance? What significance was the EKG finding of an inverted T wave in leads 3 and AVF and an enlarged tall P wave in leads 2 for this case? What could the EKG potentially indicate regarding the patient's pulmonary status? What is the correlation between the patient's first visit to the urgent care with right-sided chest pain after 1 week and then developing left-sided chest pain with a primary diagnosis now of pulmonary embolism? If you were the healthcare provider managing this patient the initial time he visited you, which is the second urgent care visit, what would you do differently to appropriately diagnose and treat the patient? Thank you so much and have a wonderful day.